Hi, good morning everyone, and welcome to our webinar, Beyond Time and Task, Whole System Presentation. This will be the first in a series of 4 webinars looking at outcomes within various care sector services. We'll be looking at the ideas behind it. When I refer to care service sectors, I'm referring to disability, mental health, aged care, and other community support services. So let's begin with a brief introduction about today. So as mentioned previously, this is the first of a series of 4 webinars looking at outcomes and their impact on personalisation for our participants. Looking at these themes on a system level, but also on a provider level, highlighting the role technology plays, and that is definitely apparent with what's been happening for nearly the past 2 years with the pandemic. Also looking at iPlanet's client management system and looking at how that this might impact the future of care services sector. But today we're looking at the sector-wide presentation and how we can personalize it and how technology can fit into that, and particularly how iPlanet can fit into that. So when we talk about the care services system, we have a basic breakdown. We have on 2 ends of the spectrum at the moment. One side, people living fully independent, looking after themselves, using strengths-based approaches and supplementary services for support to maintain their independence and choice. Then on the other end, where there's red, the permanent support end, where there's least independent services that someone could receive. These services are areas such as specialised in-home care, accommodation, residential services, and palliative care. Moving towards the middle, you can see on the more independent side, the green area, we have independence with informal supports. These are participants or people supported by family members, accessing the community, or various support services. On the other end of the spectrum, we have the crisis support. So areas requiring immediate crisis support. If we then look at the independence with formal supports, there's things covered off such as respite, supported living, specialised disability accommodation services, the health direct telehealth services that we have, and various government agency support services. Then we also move towards the middle, where we have temporary preventative support and intensive reactive support. So things such as respite, community nurses, having short breaks, re-engagement or re-enablement services to ensure that we try to maintain as much independence as possible. Prevention services, so gap services, identifying the gaps from hospital to community-based mental health support if we're needed in such areas, and other areas such as therapy, allied health, physio, counselling, and etc. So what we aim to do, and what the main thing is that we want to have a general idea of keeping people as far left to the green and as most independent as possible. These services do tend to be independent of each other, as we're aware, but it's likely that someone moving in between these various services at each stage of their lives, that they go through a process of care planning again, and we have to be aware and look at how we personalise those processes. But in saying so, the sector is moving away from time and task. Unfortunately, a lot of these support services that we do is based on time and task due to previous disability or sector models that we have. So when we talk about input focus, time and task, I'm talking about support planning and care planning and how we measure that and how it is delivered, rather than just through a series of tick lists, checklists of what we've been doing, and the same thing applies every single day. We get up, or what our participants or people we support, they get up, they have a shower, they get dry, they get dressed, They go and make their breakfast. They eat their breakfast. They wash up, brush their teeth, and etc. And then they continue this for Tuesday, Wednesday, Thursday, and so forth. Now, when we think about this kind of approach creates dependency. You're doing things for people rather than with them, and it lacks personalization. This creates a menu of services that a person accessing the provider gets to choose from, kind of like a tick list, rather than personalized systems to them. An analogy of one of our UK client director uses is that, when you are catching up with friends or having a dinner party, do you talk about, I got up at 6:30 this morning, I had a shower at 7 o'clock, I ate my breakfast at 7:15, I had my medication at 7:30. No, we don't talk about our weekends or a time spent like that. Instead, what do we talk about? These are the things that we do on a day-to-day basis before life starts. What we talk about is, or the things that we do, is new jobs, going on holidays, going on trips, reading books, making friends, learning new hobbies, skills, being healthy, cooking dinners, and all these other aspirations and goals, rather than an input, task, tick list, menu kind of based system. So unfortunately, as mentioned, this kind of approach has stemmed from, previous systems through block funding rather than outcomes-based and person-centered based. So when we talk about outcomes, let's look at what we mean. So outcomes describe what a person wants to achieve. And there's several types of outcomes, but the main ones that we're going to be talking about today are achievement and goal outcomes, prevention outcomes, and maintenance outcomes. So what are these? So achievement outcomes or goal outcomes is something that the participant or person wants to achieve or do, whether it may be learning a new instrument, musical instrument. Prevention outcomes is something where a participant wants support or to access a service to have them not to do something again. So what I mean by that is that, someone does not want to go to hospital again after 7-4. So providing services that prevent, those kind of outcomes reoccurring again. We also then have the maintenance outcomes, and basically it's just, in reference to someone maintaining their level of independence and not, then slipping down and needing more dependent services. So when we're looking at outcomes, some things we should consider are that they should be driven by the person's aspirations. If we're saying that we're a truly person-centered organization or an organization that wants to provide personalized systems or services, we need to look at what the person wants, not what we as a service provider can offer them. And as mentioned previously, kind of like a menu-based, pick what we are given. So what can we do as an organization to help them achieve it? Outcomes should, as you know, be realistic, need to be driven by the person's aspirations, achievable, meaningful, and also within my experience as yourselves, that outcomes need to be evolving and changing. Some of the outcomes that I've seen previously as yourself, you may have seen is quite generic, quite basic and achievable, and they're more designed for the service provider rather than the participant. So as mentioned, when things change, so do their aspiration and goals, and we need to ensure that we're always evolving and changing our focus as life shifts and that our services and supports reflect that. What we sometimes fall into the trap of is, identifying outcomes that are incorrect. Things such as, I want to go to day program. That's not an outcome. That is, that's part of planning and support planning. I want a accessible shower fitted. That is part of a service. I would like more care and support. That is a request, not an outcome. We need to ensure that we base it around what the person wants to achieve or what they aspire to. And even though we work in various sectors, whether it be mental health, disability, aged care, community drop-ins, what needs to be considered and is important is that the people's outcomes remain consistent throughout whatever support services that they receive throughout their lives, and that we're working towards the same sort of goals and achievements that they want. And that is where technology comes in and has a real part to play. So when we're looking at technology, some things that can help us is obviously technology enables communication between various services. So we can ensure that the information is, up to date, current, relevant. The portability of it makes those messages, outcomes, guidance, instructions, and specific needs of the participants or the person. It is portable, accessible when we're out in the community, and we can make sure that we are actually working towards identified goals and not just goals that we assume that the person needs or wants. In doing so, there may be a level of integration that is required, but technology allows this sort of integration to be done seamlessly. So it could be things like, for example, we're looking at a set of standard data, a support plan that we may need to export to be proactive when a person goes and enters respite, so they can have that same sort of support care planning involved. Obviously, the consistency of support, that they receive is the same, regardless of which support service that they may be using. And also real-time data. I plan it with a number of other, cloud-based systems. We are looking at real data. So support plans are always up to date. The outcomes that a person wants to achieve are always accurate and, as mentioned, up to date. A person who may have attended respite 6 months ago may have a different set of goals by the time they come back into the service. So we need to ensure that information and data is reflective in real time. Also, another thing that is beneficial in the role of technology is quality monitoring. I plan it amongst other CMS systems and have real-time monitoring, which really improves quality and safety for people we support. But not also that, on a provider level, it allows us to evidence the good work that we are doing. So technology can really support a person-centered approach in which, if we're going to personalize a system and a service, we need to ensure that we are doing this on a local level and on a local service level as well. So just to quickly move along, a person-centered approach, we'll look at the two models. Our CEO, Declan, actually founded Aspirico based on personal experiences, accessing various types of support services. And what was found was the traditional approach of the legacy systems, they're more heavy-based, paper-based processes that were more designed for the provider, and the person was boxed into this model. But over the last few years, things have been changing. We've been moving more to a person-centered approach where outcomes focus, aspirations, people have more choice and control over their care and support planning. So what are the things we need to be aware of, and what are the things that we're going to try to achieve and work towards? So the more older traditional legacy systems, they're more generic. Personal circumstances are not considered. It's kind of take what you get given, as opposed to a person-centered approach, which is far more independent. We're looking at how people can maintain their current daily activities or independent skills, connecting with people, and making sure that the appropriate supports are relevant and in place for those for our participants or people. The traditional legacy systems, they're more institutional based, kind of the same care for everyone, box everyone in the same kind of support requirements, rather than having support wrapped and based around to the person, which motivates them and encourages them for some self-independence. We also have, when we're looking at the traditional systems, we're looking at more so what the person can't do, what their deficits are, compared to what, the person-centered approach is more strengths-based approach. For example, Bob is unable to do this, so we are going to do X, Y, Z for him, compared to, what was Bob good at, what has worked in the past, how did the person feel, how did they react, how did they engage in that particular task. So things, for example, with Bob did gardening in a previously, but he stopped doing that due to poor planning from a previous service provider. Some things, could we look at, active support, planning centre tools and look at getting Bob back into gardening with specific aids. Could Bob produce more quantities of fruit, share with his friends and family? Could he maybe even turn that into a little side business, you know, for some extra cash? So things that we can start looking, exploring with our participants and people, and really make this about them rather than, you know, ticking off boxes. Also, input focus, measured progress by how many tasks someone has done, you know, time and task orientated rather than outcome focus. And just to wrap this up, the comparison, you know, traditionally we're more of a risk adverse approach, where we say, okay, we're telling people what they can't do and what they shouldn't be doing because we're afraid of the risk, rather than a person-centered approach, which is much more risk aware, that we're willing to prepare for potential risk because we know what their strengths are, we can build on their strengths, rather than saying, no, we can't do this, and then, you know, obviously discouraging our participants and people, and they've had enough of that in their time. So with these principles, that is how iPlan is based when it was built many years ago, and we have been working with our customers and providers in the sector since.